SLE. This is one of the most common connective tissue disorders in the pediatric age group. So, SLE is a chronic multi-system inflammatory autoimmune disorder characterized by formation of autoantibodies directed against self-antigens and immune complex formation resulting in damage to essentially any organ. Epidemiology: although SLE affects primarily women of childbearing age, approximately 5% of cases present in childhood, mainly around puberty. SLE is rare in children younger than 9 years of age, although there is a female predominance of this disease in adolescence and adulthood. There is an equal gender distribution in children, and the overall prevalence of SLE in the pediatric population is 10 to 25% per 1 lakh children. So in adults it is more common in women, and in children it is equally common in both the genders. It is SLE. This is a chronic autoimmune disease and mainly affects the blood vessels and the connective tissues. So going into the history, lupus is a Latin word for wolf. Erythematosus means red rashes. In 1851, Dr. Cazenave discovered red rashes on the patient's face that look like wolf bites. He named the rash discoid lupus erythematosus. In 1885, Sir William Osler recognized that many people with lupus had a disease involving not only the skin but many other organs or systems. He named this disease as SLE, that is systemic lupus erythematosus. So SLE, one that most people refer to when they say lupus. So the symptoms of SLE may be mild or serious, although SLE usually first affects people between ages 14 to 45 years, and it can occur in childhood or later in life as well. So discoid lupus erythematosus, a chronic skin disorder in which a red raised rash appears on the face, scalp, or elsewhere. The raised areas may become thick and scaly and may cause scarring. So the rash may last for days or years and may recur later. A small percentage of people with discoid lupus have to develop SLE later. So neonatal lupus, this is very rare disorder and seen in only newborns. And scientists suspect that neonatal lupus is caused by autoantibodies in the mother's blood called anti-RO and anti-LA. Autoantibodies are blood proteins that act against the body's own parts. At birth, the baby presents with skin rashes, liver and cardiac involvement is also there, and blood counts are usually low. These symptoms gradually go away after several months, although it is rare in cases. And yeah, so some drugs may cause SLE-like features and hence called drug-induced lupus. So the features typically go completely when the drug is stopped, and brain and kidneys are rarely involved in this. That is drug-induced lupus. So cardiac. So clinical features of SLE. So in cardiac, the cardiac manifestations include endocarditis, myocarditis, and pericarditis. Constitutional, like fever, fatigue, weight loss. Gastrointestinal, like abdominal pain, nausea, vomiting. And dermatological problems, conditions like alopecia, butterfly rash, mucous membrane lesion, photosensitivity, purpura, Raynaud's phenomenon, urticaria, and vasculitis. So usually the most commonly child presents with dermatological complications and also constitutional symptoms like fever, fatigue, and weakness. Okay. And hematological features include a fall in all the blood counts, and that is anemia, leukopenia, and thrombocytopenia. And musculoskeletal system involvement is also very common, and it presents as arthralgia, arthritis, and myositis. The most important feature of arthritis in SLE is non-erosive. There are no joint erosion seen in SLE. And pulmonary, It is pleurisy, pulmonary hypertension, and pulmonary parenchymatous inflammation are seen. Neuropsychiatric cranial neuropathies, organic brain syndrome, peripheral neuropathy, psychosis, seizures, and transverse myelitis can be seen. And renal, there is hematuria, proteinuria, casts in urine, and nephrotic syndrome is also common. Reticuloendothelial, there is hepatomegaly, splenomegaly, and lymphadenopathy. So clinical presentation varies in different patients, and the disease activity varies over time in a single patient. So majority of patients have arthralgia of the hand. Most frequent manifestations in children include fever, rash, alopecia, arthritis, and renal involvement. Compared with adults, children have higher incidence of malar rash, anemia, leukopenia, renal and neurological involvement. So renal involvement, mostly the child presents with proteinuria and edema. So coming to the pathogenesis of SLE. So these in SLE, the basic thing that happens is there are self antibodies developed. So these self antibodies react against the own nucleus or own membranes of the body, and these produce the symptoms. So there is loss of tolerance to nuclear antigens. So anti-nuclear antibodies are formed. This is due to dysregulation of the immune system. So this causes end organ targeting, and the organs involved are kidney, brain, joints, and blood vessels. So what causes SLE? SLE is an autoimmune disorder that develops when the body's immune system begins to attack its own tissues. Its cause is unknown, but it is likely that a combination of genetic, environment, and possibly hormonal factors work together to cause SLE. This occurs through the production of autoantibodies that attack a person's own cells, thus contributing to the inflammation of various parts of the body and may cause damage to organs and tissues. The most common type of autoantibody that develops in people with SLE is called as anti-nuclear antibody, because it reacts with parts of the cell's nucleus. So the fact that SLE can run in families indicates that there is development of a genetic basis. However, no specific lupus gene has been identified yet. So studies suggest that several different genes may be involved in determining a person's likelihood of developing the disorder, which tissues and organs are affected, and the severity of disease. However, it is believed these genes alone do not determine who gets SLE, and other factors also play a role. Some of the other factors scientists are studying include sunlight, stress, certain drugs, and agents such as viruses. So diagnosis of SLE is based on clinical symptoms and lab findings. Diagnosis based on American College of Rheumatology criteria for diagnosis of definite lupus in children. So more than 4 criteria on the list, either at the present time or at some time in the past, there is a strong chance that you have lupus. So 11 common criteria or measures that was developed by the American College of Rheumatology. One is malar rash, a rash over the cheeks and nose, often in the shape of a butterfly. Discoid rash, a rash that appears red, raised, disc-shaped patches. Photosensitivity, a reaction to sun or light that causes a skin rash to appear or get worse. So oral ulcers, sores appearing in the mouth. Arthritis, joint pain, and swellings of 2 or more joints in which the bones around the joints do not become destroyed. Serositis, inflammation of linings around the lungs or inflammation of the lining around the heart that causes chest pain, which is worse with deep breathing. Kidney disorder, persistent protein or cellular gas in the urine. Neurological disorder, the most common neurological symptoms are seizures or psychosis. And blood disorders that include anemia, leukopenia, lymphopenia, or thrombocytopenia. Usually child presents with anemia, leukopenia, and thrombocytopenia. And immunological disorder, anti-DNA or anti-Smith are positive. or positive antiphospholipid antibodies. So most common are more specific for SLE are anti-double-stranded DNA antibodies. So anti-nuclear antibodies. So diagnosis of SLE is based on clinical symptoms and lab findings. So diagnosis based on SLE clinics classification criteria for SLE. So more than 4 criteria, at least 1 clinical and 1 immunological criteria. Biopsy proven lupus nephritis with positive anti-nuclear antibody or anti-double-stranded DNA. So symptom finding need not be present at the same time. So, clinical criteria: acute cutaneous lupus, including lupus malar rash, bullous rash, toxic epidermal necrolysis variant of SLE, maculopapular lupus rash, photosensitive lupus rash, or subacute cutaneous lupus. So chronic cutaneous lupus, including classic discoid rash, localized or generalized, above and below the neck, hypertrophic lupus, lupus paniculitis, mucosal lupus, lupus erythematosus, tumidus, chilblain lupus, that is a red violaceous rash over the face and neck, and discoid lupus. Oral ulcers or nasal ulcers. Oral, palate, buccal, and tongue are commonly involved. I mean, these are the most common places where ulcers are seen. In the absence of other causes such as vasculitis, Behçet's disease, infection, IBD, reactive arthritis, and food and acidic foods. So, non-scarring alopecia, diffuse thinning of hair, fragility, visible broken hairs are seen. In the absence of other causes such as alopecia areata, drugs, iron deficiency, and androgenic alopecia. Synovitis involving more than 2 joints characterized by characterized by swelling or effusion or tenderness in more than 2 joints and at least 30 minutes of morning stiffness. Renal, urine protein to creatinine ratio representing 500 mg protein for 24 hours or red blood cell CAS. Serositis, typical pleurisy for more than 1 day or pleural effusions or pleural rub. Typical pericardial pain for more than 1 day or pericardial effusion or pericardial rub or pericarditis by electrocardiography in the absence of other causes such as infection, uremia, and as well as pericarditis. So neurological seizure psychosis, mononeuritis multiplexa in the absence of other known causes such as primary vasculitis, myelitis, peripheral or cranial neuropathy in the absence of other known causes such as primary vasculitis, infections, and diabetes mellitus. Acute confusional state in the absence of other causes like toxic, metabolic, uremic, and drugs. So clinical criteria: hemolytic anemia, that is HB is always less, leukopenia at least once in the absence of other causes such as Felty syndrome, drugs, and portal hypertension, or lymphopenia at least once in the absence of other known causes such as corticosteroids, drugs, and infections. And thrombocytopenia at least once in the absence of other known causes such as drugs, portal hypertension, and TTP. So, immunological criteria: anti-nuclear antibodies level above laboratory reference range, anti-double-stranded the DNA antibody level above laboratory reference range or more than 2-fold of the reference range is tested by ELISA. So, anti-Smith, that is anti-Smith antibodies present of antibody to Smith nuclear antigen. So immunological criteria: antiphospholipid antibody positivity as determined by positive test for lupus anticoagulant, false positive test result for rapid plasma reagent, medium or high titer anticardiolipin antibody, that is immunoglobulin IgA, IgG, or IgM, positive test for anti-B2 glycoprotein, that is immuno IgA, IgG, and IgM, low complement levels, that is C3, C4, and CH50, and direct Coombs test positive in the absence of hemolytic anemia. So monitoring during clinical visit should include thorough clinical examination and history, and should follow laboratory investigations. And the laboratory investigations include a complete blood count, creatinine measurements, and urine analysis to know the involvement of kidney. So results of lab tests that may precede a disease flare. So decrease in serum complement levels, increase in double-stranded DNA, increase in ESR, decrease in HB, leukocytes and platelet count, increase in CPK levels, appearance of microscopic hematuria or proteinuria. So goals of treatment. So control disease manifestation, allow child to have good quality of life throughout major exacerbations, prevent serious organ damage that adversely affects function or lifespan, prevent adverse effects of the drugs used. So pharmacotherapy should include corticosteroids, immunosuppressants, NSAIDs, and sunscreen over the rash. So oral corticosteroids, patients with mild SLE do not normally require use of systemic corticosteroids, but there are patients who have low quality of life if not given low dose corticosteroids. So lowest possible dose should be used for maintenance therapy. High dose corticosteroids are necessary for refractory manifestations of SLE or for severe organ systems manifestations, especially CNS, renal, and hematological manifestations. So decreases inflammation by suppression of immune system. Topical corticosteroids, helpful for discoid lesions, especially on the scalp. Use a less potent steroid on the face because it is more prone to atrophy. So corticosteroids, parenteral corticosteroids, pulse therapy of IV corticosteroids in combination with immunosuppressive agents is recommended for class 3 and class 4 SLE patients with confirmed glomerulonephritis. So other drug used in the treatment of SLE is HCQs, used for skin and joint manifestations, also used for preventing flares and other constitutional symptoms. Inhibits chemotaxis of eosinophils and locomotion of neutrophils and impairs complement-dependent antigen-antibody reactions. Recommended as background treatment for class 4 and class 3 and class 4 SLE patients with nephritis. So immunosuppressants, these agents act as immunosuppressive, cytotoxic, and anti-inflammatory agents. In the treatment of severe CNS and severe glomerulonephritis, thrombocytopenia, anemia, and high-dose glucosteroids and immunosuppressants are used. Concomitant use of corticosteroids allow lower doses of immunosuppressants. So these are like azathioprine, cyclophosphamide, IV immunoglobulins, methotrexate, and beculizumab. NSAIDs, these drugs provide symptomatic relief of fever, arthritis, and mild sinusitis. Inhibit inflammatory reactions and pain by decreasing prostaglandin synthesis. SLE patients have a high incidence of NSAID-induced hepatotoxicity. So sunscreen, patients with SLE should apply sunscreen with at least an SPF of 15 to prevent dermal and systemic disease flares upon exposure to UV light. So complications. Some degree of long-term and often permanent organ dysfunction from either SLE or its treatment have been found in 88% of patients. And this includes hypertension, growth retardation. This can be due to the disease or usage of steroids, chronic pulmonary impairment, ocular abnormalities, permanent renal damage, neuropsychiatric symptoms, musculoskeletal damage, and gonadal impairment. Outcomes of SLE outcomes for SLE have improved significantly over the past several decades and depend largely and depend largely on the organ systems that are involved. Worse prognosis are seen in patients with SLE or cerebritis with risk of chronic disability or progression to renal failure. With current therapy for the disease and the success of renal transplantation, however, most patients live well into adulthood. Thank you.
చెప్పండి.
If you have any doubts, please let me know. Close చేసాను ఇది.